Great. Hello, everyone. Welcome to today's webinar. This is Mike Steckline, partner with the Institute for Enterprise Excellence. Real treat today. We've got a presentation with a friend and colleague, Dr. Paul DeChant, who I met a number of years ago, did some work together, and he's going to do a presentation on some of the things that he's passionate about and trying to improve relative to provider burnout. And I'm going to go through some intro slides and then quickly turn it over to him so he can get to his materials. Just so you know, we've got phones that are muted. There will be some Q&A time when I can unmute them later. You can always use the chat function on the computer to type in some questions or any comments. And then we will have time at the end of the webinar for some Q&A. This is being recorded so that people can take advantage of that after the webinar. So with that, I'm going to turn it over to Dr. DeChant, who's going to provide us with the overview of some of the materials that he's put together for today's presentation. Paul, you got the controls.
Thank you so much, Mike. Good morning or afternoon, everybody. I'm on the West Coast, so it's still morning for me. Just a brief introduction so you know who I am and why I think I can talk about this subject of physician burnout. I am a family physician. I practiced for 25 years. I worked as during that time, I had progressive roles in management in large medical groups. Ultimately became CEO of a 300 physician group in the Central Valley of California, the Sutter Gould Medical Foundation. And during that time, realized that lean was a great opportunity to address the real problems in medical care today. Certainly all of the workflow and other challenging issues, but by doing that, we could actually reduce burnout because burnout has become such an overwhelming topic for physicians. And so that's the approach. I was CEO there for 5 years. By the end of that time, we had achieved great results. We actually got recognized by Consumer Reports and a California Health Performance Institute as the overall highest performer out of 170 groups in the state of California 2 years in a row. And we moved our physician satisfaction from the 45th percentile up to the 87th percentile on the American Medical Group Association's provider satisfaction survey. So we really moved the bar. After 5 years, Simpler, the lean consulting firm that had helped us do that, offered me an opportunity to be an executive coach at health system leadership around the country with other clients. So I've been doing that for the last 5 years, and about 3 months ago went independent with my own consulting practice. During this past 5 years, I've consulted in probably 30 or 40 healthcare systems. I've spoken internationally, probably given 100 presentations, and I've co-authored a book on preventing physician burnout, curing the chaos, and returning joy to patient care. You can find that in Kindle version on Amazon. With all of that, I really appreciate this opportunity to hopefully give you a different understanding of burnout and what we can do to fix the workplace, not simply fix the workers. To start with, rather than talking about burnout, I want to talk about the opposite of it, which is professional satisfaction. And for physicians, what drives professional satisfaction is meaningful patient relationships, because we have this unique opportunity in our role where people come to us and trust us deeply. They'll tell us things they won't tell anyone else in the world. They'll let us examine parts of their body they let no one else see, because they know we have their best interest at heart and we've got the training and skills we need in order to actually take great care of them. And that is such a unique and wonderful opportunity to have as a profession, that the more time as physicians, and this actually applies to nurses and other clinicians as well, the more time as clinicians we can spend in this realm of our work, the less burnout we will experience. And the key is to get to the point where we can spend more and more time here, and that's what we use lean to achieve. So that's professional satisfaction. What's the opposite of it? What's driving burnout? What's driving burnout is we take these highly motivated clinicians and we put them into a clinical workplace. The problem is that clinical workplace is so dysfunctional that clinicians have to be constantly vigilant and focused in order to make sure we don't make mistakes, things don't go wrong, and our patients get great care. And we can be vigilant and focused for short periods of time, and it's pretty exciting and rewarding. If big trauma comes in the ER, there's a family crisis we help people through. But when it's consistent all the time and we can't get a break, it's unsustainable. And that leads to toxicity. And you'll see later why I actually put skulls and crossbones in there and why toxicity is the reality of that. And in fact, Maslow and Leiter, Christina Maslow is the one that created the Maslow Burnout Inventory, one of the deepest researchers in this field. They say that burnout isn't a sign of a problem with the worker. It's a sign of major dysfunction within the organization. And that it's the workplace that's the problem, not the worker. So how did all this happen in healthcare? Well, we've got our clinician in our clinical workplace, and that workplace became toxic. It became toxic not because the administrators and executives think, well, what can we do to make our clinicians' lives miserable? They're thinking every day, how do we cope with everything that's been happening to our industry? And I'll just take you briefly through what's happened in the last 15 to 20 years that's made it such a challenge. It starts with the EHR, that computerized medical records. Now we spend all of our time entering data, typing into a keyboard instead of connected to the patient. It came along with a thing we jokingly call meaningless abuse instead of meaningful use. It's proving to the government that we're using the EHR funds they gave us in a proper way. It got complicated by a new diagnostic approach called ICD-10, which increased by a factor of 10 the number of diagnostic and procedural codes that we could use. The payers, the insurance companies, love this because they can use all of that complexity to deny payments to us or to demand prior authorizations for the care that we have recommended. And most family physicians are seeing 30 or 40 prior authorization requirements a week, the vast majority of which get approved, but they take time away from our care. The government got in this act as well with the ACA. There's other things called macro MIPS, the changes of volume to value and the formation of accountable care organizations. A lot of this is affecting payment, not just for what we do, but for how we've done it. So we're seeing quality measures that impact with payments. HCAHPS and CGCAHPS are patient satisfaction scores. If you've ever talked to a physician about their patient satisfaction scores when they're low, you know what a pleasure that is to have that conversation, because they will be happy to tell you how the patient demographics have changed. Patients are older, they're sicker, they're more culturally and linguistically diverse. The ones that are consistent with this have already consulted Dr. Google and come in not asking us for help, but telling us what they want us to do for them. Oftentimes they're asking for pain meds because we used to give pain meds freely. Pain was the fifth vital sign. Now this crisis has developed and we're denying pain meds. When we deny pain meds, we see patients come back angry and wreak violence in healthcare institutions. So maybe we should just get rid of these HCAHPS, CGCAHPS as patient satisfaction. The problem is there's another whole star system that rates us out there that we have no control over called Yelp. If you have clients who have them Yelp themselves or their entity, it's pretty interesting what you find. Sometimes the leadership says this is just too overwhelming. Let's just get bigger. We can't handle it on our own. So there's a lot of merger and acquisition activity happening that distracts leadership away from the front lines and operations, making it even harder to improve them. Physicians thankfully have their specialty societies to help them with a thing called maintenance of certification. I say thankfully tongue-in-cheek because actually maintenance of certification is a process by which physicians get tested on a regular basis every 5 to 10 years to prove, prove that they're still competent. Those tests are questionable and require a lot of time and money for physicians to prepare for those, just extra hassle. And with all of that, we're getting paid less. So you'd think that's enough. Well, of course, just in the last month or two, we've seen a whole new thing pop into place, the old coronavirus, which is just adding stress even more. When you look at all that, you think about how did all this happen? Why are physicians still coming to work? The thing is, all of these came in very gradually, and every time one came in, as long as we could still have that great interaction with our patient, that deep connection, we could handle it. So when the EHR came in, we said, well, okay, as long as we can still have our great caring relationship with our patient, we'll handle it. That maintenance of certification test, I'll put up with it if I get my patient interaction. Meaningful use, sure, I'll click a few extra boxes in the computer as long as I can still care for my patient. But we've gotten to the point where this is just overwhelming. And in fact, we have essentially added the last straw. People are overwhelmed and people are breaking. And when doctors and nurses break, what we see happen is depression, substance abuse, family dysfunction, and suicide. And physician suicide rates are significantly higher than other professionals. We lose approximately 400 physicians a year to suicide. Think about that, and hopefully that helps to understand why I consider these workplaces actually toxic. So our healthcare systems are at risk from this as well. It's not just the docs. As burnout reduces performance, and performance is impacting how much we get paid per unit of service, we're actually seeing decreased reimbursement on that basis. In addition, we're seeing less productivity because the work demands are so great that physicians simply cannot do more. In fact, the AAFP, the Family Physician, American Academy of Family Physicians, found that physicians have decreased about 15 or 16% the number of visits per week in the last 10 years. So we're seeing fewer units of service and less reimbursement per unit of service due to all of these issues. So that's pretty bad news. Let's talk about burnout. We haven't really talked about that yet. What is it? It's three things. The first is exhaustion, which means there's nothing more to give. That's the first manifestation of burnout. I am exhausted. I can't do anymore. And when we get to that point, then we start to become cynical, and it's a self-protective mechanism. When I have nothing left to give, I protect myself from my patients and from my organization. And when we put those two together, we start to feel as though we're not making a difference. And that's really, I think, the saddest thing, because patients deeply value their interaction with physicians, but physicians start to question if they're really helping their patients or not. What's driving all of this? Well, there's 6 key drivers of burnout as defined by Maslow and Leiter, and their specific applications to healthcare. The first is work overload. And in healthcare, particularly if you've worked in other industries and then you're working in healthcare, you realize that healthcare's got a pretty darn chaotic work environment with an awful lot of time pressure in it that is not seen to the same degree in other industries. On top of that, we're starting to see more information overload, not just work overload. The quantity of medical information is actually doubling every 73 days. Think about that. Every 2.5 months, the amount of information that is available to physicians in order to diagnose and treat patients is doubling every 73 days. It is impossible to keep up. When we're overloaded like that, we start to feel like we've lost control. That's the second driver of burnout. Control is a big deal to doctors. We deeply value our autonomy, and patients want us to take control when there's a crisis. And that loss of control, in fact, is one of the intangible rewards that we look for in this agreement we make with we sort of make a compact with society. We're going to commit to spending the decade of our 20s learning how to be doctors, and in return, we get a job that gives us control, it gives us professional recognition, and it gives us an opportunity for deep collegiality and connection with our fellow physicians. Insufficient reward, that's the third driver of burnout. The fourth driver has to do with that collegiality. It's actually a breakdown of community. It used to be most hospitals had a great doctor's lounge where physicians would come together throughout the day, connect with each other, talk about interesting cases, just get to, just have a little downtime together. People don't have time for this anymore. So we see less and less of it, whether it's meeting together at lunch in an office setting, whether it's in the hospital, wherever. And as that gets lost, people start to feel as though maybe as they're feeling so bad and they're not connected to each other, maybe they're not being treated fairly compared to others. Absence of fairness is the fifth driver of burnout. And there's a number of ways that doctors certainly feel that this isn't fair. Things have changed from what I agreed to initially. In addition, we're seeing more and more diversity in the physician workforce, and that's bringing a new level of fairness issues as there's more women in the workforce, more people with different ethnic backgrounds in the workforce, oftentimes not treated the same as somebody like me. I'm an old white guy, pale, stale male. Nobody ever challenged me into whether I had the credentials and ability to care for them, whereas it happens frequently with people who, for women or for people of different ethnicities. And then lastly, on top of all that, we start to question whether our values aligned with the values of the organization that we're working for. We see this as health systems are making decisions to keep their bottom line intact, because if we don't have a margin, we can't live our mission. But those decisions sometimes seem to fly in the face of physicians of what other values have been stated, such as improving quality and patient service. We can actually, Maslow's done research that has linked these to the manifestations of burnout. So work overload actually is linked to emotional exhaustion, that first manifestation of burnout. The other 5 drivers, though, are the things that drive cynicism. So you can, and what we see commonly in patterns of physician burnout is almost everyone's got exhaustion because there's so much work to do. But about half of burned out physicians will have cynicism and the other half don't. And that really speaks to the quality of the management system and the organization in which people are working. In fact, the opposite of emotional exhaustion and cynicism are energy and engagement. And you're probably, if you work in health systems, work with some system that is working hard to increase its engagement scores. The best way to do that is to work on a lean management system that actually addresses those 5 drivers of burnout. So this is pretty bad. What do we do about all this? Just to realize the challenge is significant. As Peter Drucker, famous management guru, said, healthcare is the most complex, difficult, and chaotic industry to manage. So if managers are feeling overwhelmed, we have to, we understand it's for a good reason. There was recently a 330-page book that came out from the National Academy of Medicine addressing burnout. For people that are deeply interested in this, they might find it valuable. But it's written at a fairly academic level. It's full of great resources, but it may be tough to read and get a clear idea of what do you do about all this. So I'm going to talk about that for the next 20 minutes or so here. And I like to think of it as 5 steps to address burnout. You see that diagram, a picture on the right-hand side there. The center of that is professional fulfillment. Remember, we talked about that at the start. What fulfills physicians? The things that impact that fulfillment are those 3 sections around it. So, bottom there, personal resilience. That is our ability to cope with the situation. The second is to the right, efficiency of practice. This is a term the idea of efficiency of practice can scare physicians if you talk to them about that, because they're going to think you're going to want them to produce more RVUs, or see more patients, have more visits, and they're already feeling overwhelmed. I see efficiency of practice as meaning actually, how do we get rid of all the barriers and frustrations to connecting to my patient? How do I get rid of all that administrivia and data entry and let me spend time connected to my patient? And we'll talk about that. And then the third one is culture of wellness. This, to me, is the heart of a lean management system and culture, and you'll see us dig into that. So we start with the diagnostic workup, and then we have a planning session, and then we talk about those 3 areas that we want to focus on. We'll go a little more into each of those. With the diagnostic workup, there's a number of assessments we want to know about. First is a burnout survey, because we're looking at this, and there are actually good surveys out there. The Maslow Burnout Survey, the MBI, accompanied by the AWS Area of Work Life Survey, which identifies those 6 drivers of burnout, I find very helpful, because I can then know what are people experiencing and what's driving it. And as we know, when we understand the root cause drivers, we can actually address the heart of the problem and make a difference. But there's a number of surveys out there. If an entity has already done a survey, I don't ask them to redo it until we see if we need it. We'll use the information they've got. I also want to know about their KPIs, because we have to make sure that as we do this work, we improve performance and improve the bottom line. It's not, if we don't improve the bottom line, if we are not sustainable, there's no point in doing this work. Leadership is key in this, so the more we can assess the quality of leaders at various levels in the organization, the better. The EHR is a key factor in all of this, and there are a number of different reports we can get about the function of the EHR. So if you know which EHR your team is using, you can work with the information officer team and get more about actually what's working, what's not. And then equally importantly, if not most importantly, I see shadowing clinicians as a deep value, particularly for the non-clinician leaders. This work we do in coaching others to improve their organization is to help empower those leaders to do a good job. They can have all the data. They can sit in a conference room, look at spreadsheets and reports, and we know that unless we actually go to the Gemba, essentially as a doctor, if I'm looking at the chart at all the lab results and the vital signs, but I haven't gone and examined the patient, I'm missing key information. Same thing, getting clinicians or non-clinicians in particular who aren't practicing to the clinical worksite to understand the impact of burnout is incredibly valuable. So with all of that done, what do we do next? We really take all that and use it to have a planning session. This should be similar to a strategic planning retreat, 1 or 2 days. We should bring together leadership of the non-physician and physician leadership, and we should map out exactly what we're going to do based on that diagnostic. So we have intention on what we'll do to address well-being, management system and culture, and that practice efficiency. And then we want to regularly review and check in on a monthly or quarterly basis. Is our plan actually, are we able to implement what we said we would? Are we seeing the results that we expected as a result of that? We'll talk briefly about physician well-being support. Every organization, provider organization should establish a center for physician well-being, and that should include doing things like educational sessions, peer support meetings. Sports rounds is a way that doctors come together to talk about the challenges of caring for patients, doctors and nurses. But stressed colleagues can really benefit from support, whether it's meal delivery or extra call coverage when they're having a problem, having individual physician coaches involving all of this, the well-being people and onboarding new physicians. But this is all important, but it's not sufficient. We need to also improve the workplace itself. There is one unique kind of focus, which is a thing called I refer to as 20% solution, which is that when any professional spends up to 20% of their time on their area of interest, they can spend the other 80% doing things that are not as interesting, and it really significantly reduces burnout. Some things that doctors can do that benefit their organization are to focus that 20% of time on EHR optimization, population health improvement, doing procedures, treating special needs patients, even doing teaching or research can make a big difference. So finding incremental opportunities that bring that into practice can make a difference. Let's talk about that practice efficiency. It's really about removing barriers to physician-patient interaction, which is really a healing interaction. This picture, Mike, can I go back somehow?
You can.
I see.
There you go.
So this picture was in the Journal of American Medical Association about 8 years ago. And this was drawn by a pediatric patient who was deeply thankful to her pediatrician, who was well known as one of the most wonderful docs around. He was the kind of person who would get down on his knees to be eye to eye with his pediatric patients. You see this patient there on the end of the exam table. Her mother's reading her a book. Her sister's holding a sibling in the background. And then if you look to the left, you see there's this person over there facing away from all of the typing away. That's the doctor. And for some reason, not only is he busily typing into his computer, but he's also got a smile on his face. We're not quite sure why. When this patient gave this picture to the physician to thank him, he was horrified because he realized what was happening was she viewed the interactions as him being completely disconnected from them. And that spurred him and his institution to really start to lead a big change in the process. Another way to think about this is that we've taken the highest level professional and put them into the work of doing the majority of production, customer service, and clerical work. Another way to think of it is, on an assembly line, you take the most important and expensive piece of equipment that's taking raw materials and turning them into something of value, and having it not just do that one function it does best that no one else can do, but it's also doing the quality control checks on this material. It may be doing the supply chain sourcing. It may be doing the marketing on the other end. We're doing all sorts of things that others can do, but we're having doctors end up doing it. I don't know why that came in. Sorry about that. So there's key value streams to focus on in terms of improving this work. And And we'll talk about each of these four. The first one being looking at a way to build a team around the physician so that others are doing work that the doctor doesn't have to do. Usually this means adding 2 to 4 medical assistants, RN, nurses, or others to support the physician. But when we do this, and there's a lot of concern from leadership that if we add people, we're going to actually add expense, and we can't afford to do that. It actually ends up increasing the time. Doctors, and for the most part, are able to see additional patients. And then as a result, we see improvement in revenues, patient experience, physician experience, and support staff experience. This requires deep value stream work to really think through, and there are some models out there that are really helpful in terms of how to do this. But this kind of thing can make a tremendous difference. There's actually now some, we'll talk briefly about that in a minute here. EHR optimization, this is the other issue, all this data entry work, all these challenges. Understanding what's happening with the EHR through those surveys that I discussed, developing specific coaching for individual physician needs. One of these Epic Signal reports, or Lights On report, tells us which doctors are struggling and which aren't, who could benefit from some personal coaching. Redesigning the user interface by specialty. The EHR interfaces are really very user unfriendly, and making sure there's a large screen available, because those big screens actually improve efficiency significantly. One thing to think about with your clients is from the leadership of the clients, from the CIO, possibly from the CFO, because they may not want to spend the money, is whether doctors are still typing in passwords or whether they're using a process called single sign-on. Usually this is a biometric or RFID badge that can eliminate typing passwords. And most physicians will end up typing their password in anywhere from 40 to 100 times a day. We're talking 400 to 1,000 keystrokes a day spent just on typing passwords. This technology is available, and yet as I speak around the country, I see about half of organizations that claim they're trying to work on burnout aren't even doing something as fairly quick, win, and simple as putting in single sign-on. I use it as a real bellwether to tell whether an organization is serious about this or not. So be aware of this. One other thing that's actually coming out on the horizon now that's very promising are new opportunities for AI-enabled virtual scribes, or conversation to text, essentially. And there's a number of companies out now that are just starting this up, but are seeing very good results. So if you think about even just Google searching AI-enabled virtual scribes, you'll find out a lot of information, and those would be very interesting things to experiment with. The in-basket is a whole other component of the EHR that drives physicians' frustration, because there are messages coming into doctors' in-baskets all day long. Lab results, consult reports, messages from patients, messages from nursing homes and others, having these prior authorizations, all of these things. Prescription refills. There's a few key things in in-basket that can make a huge difference. First of all, no message should go first to the physician, but the physician should have a support team that receives every message, reviews it, and makes sure the physician actually needs it, because over half of them don't need to go to the doctor. We can improve message protocols to make that process work even better. There's oftentimes many folders, very complex list of folders in basket that can be reduced. And we can set up protocols so RNs can do med refills. Many places are doing some of all of this. I don't know anybody who's doing all of it. One of the key things in in-basket management is actually co-locating staff during the day. And we'll talk about that next. With clinical space redesign, often we're thinking about this as integrated facility design. For designing a brand new unit, that's great. We can do an awful lot to build a space where the physician and their support staff all sit together throughout the day. From that spot, they can see all the exam rooms. And as they're co-located, they can, when a message comes into the in-basket, the nurse or MA can simply turn to the doc and say, hey, Mrs. Smith called in about this. What do you think? They take care of it right there, instead of what's happening now quite often, which is the nurse gets that, they review it, they type a message, an email message to the doctor then has to review that. type back, and the nurse has to look at that. There's so much waste involved in that. So not every place can be designed brand new, but we can still find ways where even in fairly poorly designed old offices, there's opportunities to have teams co-locate so that when the doc's not in the exam room, they are actually sitting with their staff. And then using flag systems effectively make a big change as well. A lot of times flag systems, you'll see them around hallways, they're in, but they're not being used. So having teams learn to use those effectively can create a very quick nonverbal communication. Inside the exam room, large monitors can help. In fact, a large monitor with a half-circle desk where the patient and the doc sit side by side can help facilitate real connection. And where people are still doing a lot of printing, particularly for the follow-up information for the patient instructions, having a printer in the room rather than in the hallway ensures that the physician can finish up, print the instructions, and hand them to the patient without having to interrupt that healing interaction at the point that's most important, where the information is being shared with the patient. Every time a doctor steps out of the exam room, you never know when you're going to get back in there because there's so much going on out there where people are waiting for you to ask you a question and keep moving on from there. So that's how to fix the efficiency of the practice, how to get rid of all the things that disconnect doctors from patients and allow doctors to spend most of their time connected to patients. When we do that, right now the current average is about 2 hours of EHR work for every hour of actual connection to the patient. And if we can simply reverse that ratio, it'll have dramatic impacts. So next thing I want to talk about is the management system and culture. And for me, when I think about the management system that fights burnout, it's lean. And so when I present this to audiences, I'll say, we should pursue lean leadership. And they'll look at me and they say, Paul, you're crazy. We had lean in here. Lean is mean. Lean made things worse. And we've probably seen that. Lean does make things worse if our focus is on increasing productivity. Doctors are already plenty. The issue isn't productivity. If we're going to work from a deep management system, principled approach to lean, the key is understanding what's most important to us. And the most important thing in healthcare, in any provider organization, I'll ask audiences, it's the patient. Without a patient, we have no reason to exist. There's no reason for doctors and nurses to come to work. There's no reason to have hospitals or clinics if there's no patients. So the patient's the most important person. The most important thing that's happening to that most important person is a healing interaction that's taking place between the doctors and patients, nurses and patients, receptionists, transport people, EVS people, technologists, therapists, you name it. Every time someone in our organization interacts with a patient, it has the potential to be a healing interaction. It has the potential in some way to reduce pain and suffering, relieve some anxiety or worry, actually do something definitive to make the patient better or to educate them to be healthier. That's the heart of what we do. For myself as a family doctor for 25 years, I had over 100,000 healing interactions. But as I moved up in my management roles and eventually I became the CEO, that dot there at the bottom, I wasn't seeing patients anymore. I wasn't doing the most important thing for the most important person in my organization. Our role as leaders is to make sure that those people on the front line have what they need so they can maximize those healing interactions as they provide them to the patients. And with that management philosophy, which is at the heart of the lean management philosophy, we can make all the difference in the world. One structural point about an org chart like this is in healthcare, we've seen it be very effective to have particularly clinician leaders working in dyads so that a physician leader of a site or a physician manager, leader of a department or a division has a partner, a non-clinician administrative partner with them at every single level where they work as a team so that the docs can have that connection to the other physicians and APPs or the nurse practitioners and PAs. But the administrative, there's also an administrator there who's working closely with the rest of the staff. And people see that teamwork happen, they realize they can do that themselves as well in their sites. That with that whole approach of enabling the people on the front lines to do what's most important, that's the heart of respect for people, that key principle of lean or servant leadership. One of the people I found most impactful for myself and thinking more deeply about this is Bob Chapman. Many people probably are aware of Bob. He's done a lot of work on this. He's written a book called Everybody Matters. He's got a website called Truly Human Leadership. He had us in, he was a traditional CEO of a heavy equipment manufacturing firm and had a sudden insight one day that things could be really different if he treated every one of his employees the same way he cared for his close friends and family. And so he started to do that. And now he's got a company that does, their product are things like building bottle washers for Budweiser, but their real mission is to care deeply for everybody who works in the company and make it a place where when people come to work each day, they're excited to come to work because they're coming to work with others that care about each other. And they take that positivity, not only do they live it throughout the day, but they bring it home to their communities and their families in the evenings. And that changes, it really truly starts to change the world. If you haven't read this book, I highly encourage you to do it. In fact, I tell people read that book before they read my book. It's that impactful. Leadership is so important in reducing burnout, and this has actually been studied while at Mayo Clinic. For every increase in the leadership score, we see percentage decrease in burnout. So developed clinician leadership programs are important. And when you're a leader, as we know, it's important to be seen and heard, because once people on the front lines know something is important to the leader, they'll pay more attention to it, particularly when we're asking them to change, which is what we do. We are change agents. Key ways to do that are rounding, both shadowing clinicians to understand the challenges, and then attending huddles, not to solve the problem, but to be the coach and the mentor that helps people and develops and empowers them. A key part in healthcare organizations, particularly these days of merger and acquisition, is to pay some attention to mission, vision, and values. Something that doctors really don't tend to want to pay much attention to, but when we do, because medical groups are merged together, they're getting acquired into health systems, we think we all share the same values, but in fact, quite often we've got some differences. Creating a compact can help bring the organization back together and align people in a way that it wouldn't otherwise. The compact is a document that describes reciprocal agreements of how we'll honor a value. So if the organization says, quality is an important value to us, and we're going to live that by closing care gaps at every visit or building processes so there can be no errors. That's not done. Just that process isn't just an expectation for the frontline worker to close that care gap, but it's an expectation that the organization is going to provide the resources those frontline workers need so that they can in fact do that effectively. And by doing that, it builds alignment and trust between leadership and frontline physicians. And currently there is so little trust and alignment in that between those two entities. It's one of our biggest challenges these days. A lot of this compact work comes out of a book that's highlighted at the bottom there. And this has been instrumental in empowering the kind of transformational change that we pursue. This whole idea of building things in this way, I like to think of it as fixing broken patient care processes, but we do it by eliminating the frustrations that physicians and nurses see. And as we know, we don't come and tell people what to do. This work has to be led and driven by physicians, by clinicians in their clinical work sites. We can act as mentors to help them do it more effectively. And when we're doing this, I see a lot of healthcare now enamored with design thinking. And they come to me and say, well, lean's kind of old hat, now we're doing design thinking. The way this is described on this slide, that's the heart of design thinking. The users actually have the input that leads to the improvement, whether it's in a process or a product. And we've been doing design thinking for a long time. It's just been named something new, and so people think it might be easier and sexier, so they pursue it that way. We all know about this, the value stream function, mapping that seems to be at the heart of lean. It's what people often think that's all lean is. But instead of saying we're fixing defects, I describe it as removing barriers and frustrations. It's done by the people who do the work. Therefore, we need doctors and nurses engaged in this. And this may be, if you work in healthcare and you haven't had this challenge, I'd be a little surprised to say we're going to make it. We're working on a workflow process improvement, and it's a key component of the office visit. We want to ask a doctor to get involved in spending a week on a rapid improvement event where we're going to improve the way that a patient checks in at the front desk, or the patient gets a room from the reception area into the exam room before the doctor enters the room. And we'll go to the doctor and ask them to spend 3 or 4 days with us dedicated only to doing this. And they'll tell us, oh, I'm too important. I can't do that. My patients need me and my colleagues need me. So I'll ask them, do you ever take a vacation because you want to replenish yourself, rejuvenate, kind of get away from it? Or do you ever go to a continuing CME, continuing medical education course because you want to stay current? When you're on vacation or at a CME course, you're not there for your patients. You're not there for your colleagues. And yet when you come back within a half a day, if not a half an hour, whatever rejuvenation you got from your vacation is gone because you come back to chaos and you can't implement any new ideas you've learned at the CME course because it's so chaotic. The most important time you spend away would be the time that you're actually improving your workplace. Because then when you come back from vacation or CME, you're coming back to some place that you're happy to come back to, not some place that's chaos. And we need physicians and nurses involved in this so we make the right decisions to improve things properly. Huddles, we all know about huddles, but surprisingly, so many people in healthcare think they know about huddles, but I don't see them doing as effectively. Never more than 15 minutes standing up at the huddle board for visual management. Acknowledgement and appreciation, having a minute to do this makes a big difference. Remember, insufficient rewards, one of those drivers of burnout. Preparing for the day, do we have the capacity to meet the demand? What's the schedule compared to the staffing? What's the, do we have all the equipment? Is it working? Do we have the supplies we need? Problem solving, fixing pebbles in your shoes. Lots of little things go wrong every day seeing patients, and it used to drive me crazy, and I'd swear I wouldn't let it happen again. I'd open a drawer and the equipment wasn't there. I needed to go to the printer and the paper wasn't in it. But I never, somehow those never rose to a high enough level that we actually addressed them. When it happens now, people go and stick a note about it on the huddle board. You talk about it the next day. It doesn't matter if you forget it later in the day, but you gradually take these little problems, these pebbles in our shoes, and fix them. And then metric performance, 1 metric a day. We don't want to look at more than 1 metric each day, but we can see if we're on track, awesome. If not, then let's start doing some countermeasures to address that issue. With this management system in this process, we take our huddles, we prepare for the day, we tier the huddle so we can escalate problems as needed. And so people from the front line, so C-level can know what's happening. The C-level though needs to communicate to the front lines. What's important to us? What is this contact? And what are the metrics, the TrueNorth metrics that make that up, that we're focused on, so everyone can become aligned around what's important to us. And that includes the human development metrics of engagement and joy in patient care. Oftentimes that's a tough one to get. And the places I see that are becoming truly enlightened on this actually build a tangible metric into the bonusing of the C-suite members that's aligned to reducing burnout. It might be something like reducing the number of clicks in the EHR, or reducing the after hours time that physicians are working on the EHR. And things like that then can motivate the CIO and the CFO to be more ready to do something like implement a single sign-on solution to reduce password entry. And so at the C-level, we've done that work. We've got mission, vision, values, and metrics. Dyad and triad leadership teams where we're acting as coaches and mentors and shadowing physicians. When we have this structure in place, where we've got communication flowing both ways from the C-suite to the front line and back, what we end up with is this management system and culture where everyone is empowered and aligned, solving problems. And with that, we can actually quickly adapt to any of those external environmental changes. All those things in that outer circle that were driving burnout, we can adapt to more effectively. And as Darwin said, the key to survival isn't being the strongest or the richest or or the most powerful, it's being the most responsive to change. This whole approach, which really is a lean management approach, makes us the most responsive to change. It's a key strategic advantage when we can deal with an uncertain environment. What happens when we do this? Well, our experience at Gould, as I mentioned, we got recognized as the top performer in the state 2 years in a row. We moved our physician satisfaction from the 45th up to the 87th percentile. And so essentially, what's happened is over the last 10, 15 years, there's been a focus on a thing called the triple aim. For those who don't know, that came out from the Institute for Healthcare Improvement, and the idea is that we are improving quality, we're improving the experience, and we're reducing the cost. In fact, some of that's driven burnout because it didn't take into account the experience of the caregivers. So we've now have this concept of the quadruple aim, which adds care for the caregivers, joy in patient care, and professional satisfaction. And when all that comes together, on a human level, I think it was best expressed by this doc who I worked with in a little clinic in Georgia, part of a larger system. He was a 35-year-old guy. They engaged deeply in this work, and at the end of it, he said, you know, I didn't think I could keep working for another 5 years, but now my life is better. I have time to exercise, spend time with my family. It's balanced. I can see myself practicing for 20 or 30 years. But the only concern I've got now is I'm worried my salary is going to go down because this is easier. There's no way I'm as productive as I was before. It turned out he was actually up 10% in his productivity. And in fact, we hadn't added additional staff to his office. We had just rearranged the staff so they were spending more time helping him and less time on other things that weren't as necessary as we learned using our lean, making changes and removing waste from all the steps throughout that office. And this is transformational when we see increased productivity and we see physicians happy to continue practicing for their full career that they prepared themselves for. So the question then becomes, what will you do to help? And how will you, and you can ask, how do we get people supporting their colleagues, fixing workflows, improving culture, and preventing burnout? And now we can get into some, oh, sorry, you know what? I think, Mike, I must have sent you a slide set that is.
You got something.
Yeah. So here we are. So it's time. That's the end of the presentation, and I'm ready to be happy to discuss any.
Okay, great. So, Paul, that was great. I appreciate that. I am going to unmute the phones, and if anybody has any questions or comments, please do. You can also use the chat function. Sounds like there's a dog that has a question.
Oh, that's my dog. I'm going to mute while your questions are being asked.
That's fine. That's cool. I'm going to put your contact information up there so that if that's what you were looking for.
Yeah, great. Thank you. And please feel free, anyone who's interested, just email me directly. I'm happy to talk to you more. I'll be glad to send you a PDF with a slide set, and happy to do any. This is my passion, obviously. Just happy to talk to anybody about how I might be able to help.
Yeah, that's great. I really appreciate this. I think a lot of people are going to benefit from this, and I know some people that I want to forward the link to for the recording, and I'm sure others will do that as well. And so I really appreciate you taking the time to do this. Looks like there's a comment or a question here. So Fozzie has a question. What were the major challenges to sell the ideas to your team and organization?
Great question. I think the first challenge was skepticism. People are so burned out. From the physician side, they're so burned out. They've had so many what feel like empty promises before of people saying they're going to help them and they don't see it happen. And so it takes time to build the trust that yes, indeed, we are here and we've got something that will really help you. A lot of overcoming that is just meeting people, talking, just so much communication at the start. All those for people who've read Cotter's Leading Change book, there's an 8-step process he's got. We used a lot of that in the process. For leadership, if you're approaching this with C-suite leaders in healthcare systems, they're very skeptical as well. Most people think that to address burnout, you can reduce workload, you can spend money on wellness programs, but that's really all there is to do. And of course, both of those will negatively impact the margin, and most health systems don't have a large enough margin to handle such an impact.
Mm-hmm.
So getting them to understand that, in fact, we can improve productivity while we're investing in this is important. And one way to help address that issue is to think, is this question of what is the physician's role really? Are they a line production worker and they're simply a cost of doing business? Or are they a skilled knowledge worker who brings great value to the organization and they're actually an asset? So asking, when you talk to CEOs or CFOs about this, addressing that concept is this person, this physician who's burning out, are they an asset on our balance sheet that's actually going to drive more benefit to the organization, or are they simply a line item expense on the income statement and we simply have to manage it? Too many C-level people are thinking this is an expense to manage, not an asset to enhance.
Yeah, a big change needed there in thinking. Appreciate that. There's a follow-up question. This is a big undertaking. What would be the first thing to do? In addition to read your book or read the other book that you recommended, I suppose.
Right. I think you have to find where in the organization that you're working with is there actually openness to making these changes and improvements. Mm-hmm. Because that's where, certainly my experience in Lean is, if I'm trying to push against resistance, I waste a heck of a lot of energy. If I've got somebody who's interested and it's more of a pull process where I'm bringing them along, that's certainly a much better use of my energy, and it's a much more positive experience. So if it's at the C-level, you've got an enlightened leader who can engage people and work there. If it's down at the front lines where you've got some, a doctor, whether it's in the ED or in an office or the OR, you've got somebody who says, I think we can make things better, and maybe that's the best place to work. And then getting clear about your message and building that core team around you of like-minded individuals who are going to help with this. Basically, those things that Cotter talked about. You've got to build your guiding coalition. You've got to get the message clear and communicate it well, and then find your opportunity to start to work. As things start to change, then you'll see improvement. So it might be huddling and doing a daily management system in one site. It might be, changing actually doing a full value stream on how a patient flows through the ED. It might be a strategy deployment at the C-suite level. You find the opening and go with where you've got pull, don't push.
I think that's great advice. That really makes a lot of sense, and it resonates with what I've experienced as well. I appreciate that. I appreciate you providing your contact information, and I'm confident you're going to get some questions and follow-up from folks on this, so I really appreciate that, Paul. So what I'm going to do, was there a question?
Yes, this is Marion. I am a ICF certified coach, leadership and organizational effectiveness coach, and I would like to target physicians as a target audience for my coaching. Do you feel it's necessary to be a physician in order to coach physicians?
No, I don't think it's necessary, but I think it's necessary to really understand. If you don't understand the clinical workplace and workflows, then it's going to be much more challenging. And it depends on what the physician is looking for coaching in. If it's a physician executive who is learning, really working to become a more effective executive, then you can be an executive coach who can make a big difference. If it's a physician who is looking more for coaching on how to get through their day better, how to work with their staff better, then having a clinical understanding is more important. The more you understand the industry, the easier it is. But there are certainly people who can be very effective coaches who aren't deeply industry experienced if they have been able to coach others effectively.
I did work as an RN, but it was many, many years ago.
Now, if you've been there, you've probably experienced, hopefully some of what I was describing resonated with you. And if that's the case, that you've got a good start.
Thank you.
That's great. Great question. As a follow-up question, can we get the PDF version of the presentation? Paul, I think you agreed that if anybody wants to get that through you, they can get that. Is that right, Paul?
Yep.
Okay.
Simply email me and I'll be glad to send it to you.
And Tim has a question. When you spoke about the opportunities around the EMR design and facility space considerations, have the leaders over those areas been key in this journey?
The more you get them engaged, absolutely. You can't, with the EHR, you do need the CIO or the CMIO, the Chief Medical Information Officer, to be engaged in the process. If they're not interested, then you really can't make changes. But it's a rare CMIO or CIO who's not aware of these challenges and interested in, they would love to find a way where the physicians were complaining less to them about the IT experience that the physicians have. So usually there is an opportunity there, and if somebody's finding particular resistance there, I'd be happy to just jump on the phone with you and talk about it a little bit.
That's great. Appreciate that. So what I'm going to do is talk about next steps, and we can close this down. Several people have expressed interest in the recording link, so I'll have to go through those steps. So what happens next, if you go to our website, you can see in the webinars section that we've got, this will be placed on the previous events. You can get the recording there. I'll also be sending out to folks that are on our distribution list. What's happening next later this month, doing a presentation on understanding and managing complexity. This is a follow-up to some concepts that we've talked about previously, and I see a lot of overlap with what Dr. DeChant talked about today. So I'll probably be bringing in some of those anecdotal examples into that as well, and that'll be on March the 20th. In April, Jason Schulist with the Generative Local Community Institute, GLCI. He's based out of Appleton. Is going to be talking about using adaptive problem solving on thorny community problems. So a little bit more on complex adaptive systems there. And there are a lot of ideas in the works. That's how these things work. I connected with Paul. He talked about an area that he wanted to talk about, and we set it up pretty quickly. And where it was able to give this within a matter of weeks. So he had an opening, we had an opening, and it worked pretty well. So that's how it's going to work. My business partner, Max Brown, has set up a podcast, and he's doing a number of podcasts that you can get, again, on our website. You can also go wherever you normally get podcasts and look for the Purpose and Principles podcast. This particular visual features interview conversation that Max had with Gerald Johnson, who's an EVP at Global Manufacturing of General Motors. And I think Paul would be interested in doing a podcast with you, Paul. So I think that would be something that we could look into the works into the future.
Sounds great.
And just a final reminder, so if you have a topic of interest that you want to learn about and talk about, or something you'd like to share, just send it my way. That's my contact information there. That's the way this works. And we are at the end of the hour, so I hope everyone has a good day, a good weekend, and stay calm with all this hectic stuff that's going on in the world. And I guess remember to wash your hands. How about that, as far as advice to go? So
I agree. As a doctor, that's great advice.
Thanks again, Paul. And thanks you for everyone that participated today. I think this was a terrific presentation. Take care.
Thanks, everyone. Bye.